Good afternoon, everyone, and welcome to the 2019 Harmony webinar series. My name is Christy Weeks, and I am the Business Development Coordinator for Harmony. Today's presentation will be facilitated by Dr. Linda Buchanan on newest developments in understanding and treating eating disorders. For those of you who are new to Harmony, we are nestled on a 43-acre campus in the Rocky Mountains just outside of Estes Park, Colorado. Our Colorado residential rehab offers comprehensive treatment for adults and their family members. Who is Harmony Foundation? Our why factor. We believe that long-term recovery from alcohol and other drugs is possible. How do we do that? As a place located between two worlds, our location in the Rockies provides a safe and quiet respite from the pain of addiction. With 50 years of treating addiction, we have fostered a generation of long-term recovery who supports our clients and families for a lifetime. Harmony staff at all levels of the organization work together to create a community of recovery support that is long-lasting. Who are we? We are a 70-bed residential treatment program located in the Rocky Mountains. We offer an evidence-based 12-step program that is gender responsive. To learn about Harmony Foundation, we invite you to visit us at www.harmonyfoundationinc.com or contact our admissions staff at 866-686-7867. Just a few housekeeping rules as we go through the presentation today. That we want to keep in mind. You will be receiving an email within an hour after the presentation. Please be sure to complete the online evaluation. You must be actively engaged in the presentation for at least 45 minutes in order to receive a certificate. We use a system that tracks how long people are engaged in the program, so anything less than 45 minutes would not qualify for a certificate through NADAC for CEUs. However, we can provide an attendance certificate if you need to jump off early. We also do provide a recorded version at the end, so if you wish to receive it, just let us know. You can contact me at that same email, cweeks@harmonyfoundationinc.com, and you will receive your certificate by Friday. If you don't, again, please let me know. I'd like to take a moment to introduce you to our presenter, but first we want to thank Walden Behavioral Care for their support and loaning us Dr. Buchanan today as we engage in this presentation. Dr. Buchanan founded Atlanta's Center for Eating Disorders in 1993, which was acquired by Walden Behavioral Care in 2017. She is now Senior Director of Clinical Services with Walden, a leading national healthcare system specializing in the treatment of eating disorders. Walden provides the full continuum of care to all genders, ages 11 and up in facilities in Georgia, Massachusetts, and Connecticut. Dr. Buchanan received her master's degree from Georgia State University and a diploma from the Psychological Studies Institute, now known as Richmond University, in Christian counseling, from which she received the Distinguished Alumnus Award in large part for her work in founding ACE. Dr. Buchanan received her PhD from Georgia State University doing a residency in the Medical College of Georgia. She has just published a book with TPI Press titled A Clinician's Guide to Dealing with Pathological Ambivalence, How to Be on Your Client's Side Without Taking a Side, the content of which she has presented both locally and nationally. She serves as a peer reviewer of American Psychological Association journals for practice innovations and was a reviewer for the APA guidelines for treating eating disorders. Dr. Buchanan has published 2 chapters on her model of treatment of eating disorders, which has been used as text in a local doctoral program for clinical psychology students. Additionally, she has published 4 research articles on the treatment of eating disorders, including 2 outcome studies of the treatment provided at Atlanta Center for Eating Disorders. She's been married for over 30 years and is the mother of 2 adopted sons. So at this point, I would really like to turn this presentation over to Dr. Buchanan.
Okay, thank you. So I'll start my slideshow now. And you read everything I've done. One thing I haven't done ever is a webinar. So we'll see how this goes. So as you already mentioned, I am from Walden, and the name of this webinar is Eating Disorders. It may not be what you think. Walden specializes in eating disorders, all ages, 11 and up, all genders, and all diagnoses. And I'm going to start by talking about some eating disorder statistics.
Dr. Buchanan, real quick, we cannot see your screen.
Oh. Okay.
It's okay.
Well, like I said, it's the first time I've done this, so do you have any suggestions?
I do. There is, I just sent it over to you, so you should have an accept button to click on.
I see that.
Click on that.
Did that do it?
Hold tight, everybody. We are having minor technical. There we go. Yep, you're good to go.
Okay, so everybody should be seeing a slide that says what we know. And that is that anorexia is the third common chronic condition for young people with after asthma and type 1 diabetes. It's more deadly or about as deadly as breast cancer, but only receives about 1/25 of the amount of funding from the NIH, just by way of example of how underrepresented and understood it is. Anorexia is the highest killer of women aged 15 to 24 of all things, mental health and other causes. Every 62 minutes, someone dies as a direct result of their eating disorder. So one person will die while I'm speaking. 30 million people in the United States currently have an eating disorder. All right, now we have another problem. Now the slides aren't advancing.
So just click on your slide and use your arrows on your computer.
Yeah.
Just regular clicks so it knows that's what you're doing.
Okay.
There you go.
All right, so I want to talk about some myths about eating disorders. The first one is that they only impact white females, young white females. And as I'm not going to go through, in fact, let me go ahead and say that I have put in a lot of information into this PowerPoint so that you will have it, the listeners, but I won't have time to go over all of it. I'll refer to it, and then if you're interested in reading more or looking at studies, you'll have this to go by. But I will point out high points. Studies from 30 different countries did not find any systematic association between ethnicity and race. 16% of transgender youth have been diagnosed with the eating disorder. That's a huge percentage of any group, 16%. And about 10 to 25%, depending on the study, of people diagnosed with eating disorders are males. Another myth is that it's just a phase. So it's just a phase that people go through like in middle school or high school and that they can just get over it. But this is pretty far from the truth. The standardized mortality rate associated with anorexia is 6, meaning 6 times higher than the general population. By way of comparison, for breast cancer, it's 4 times. And I don't mean to sound like I'm insensitive to breast cancer. I actually am a survivor of breast cancer. And as I was studying research and statistics about breast cancer, I decided to be interesting to compare to my other focus, which was eating disorders for the past 30 years. And I was kind of appalled at some of the things I learned. So I do refer to that from time to time. Females with anorexia between the ages of 15 and 24 have 12 times higher death rate than all other causes. Anorexia has the highest mortality rate of any psychiatric illness, and the mortality rate for bulimia is also elevated. On the other side of the coin, one myth is that it's just a phase, they'll get over it. The other thing we hear a lot is full recovery isn't possible. And that doesn't pan out in the research. Actually, probably about 2/3 of the people who have an eating disorder recover. 1/3 don't, and about 10 to 20% die. So, Chrissy, I have one more question for you. Are you still with me?
Yes, ma'am.
The control bar to the right is blocking some of my slide. Can I X out of that now?
If you minimize it. Can you minimize it?
I see undock or X.
Yeah, you should be able to minimize it. That way, there you go. Go ahead and X out of it. It's fine. I think.
Oh, no, I can't read around it or I would.
Can you move it?
Can I move it? Let me try that. Nope.
There should be a minimize button right at the top of that square.
Yeah. Oh, I moved it. Okay. All right, I've moved it down. We're good. Okay, so people with eating disorders, well, let me go back. The truth, I just went over the myths. The truth is that genetics slow the gun and environment pulls the trigger. It's always a combination, and that doesn't only apply to eating disorders, but it certainly does apply with people with eating disorders as well. They're born with differences in their brain chemistry. We're learning more and more about this, and I'm going to talk more about this in some detail. That shows that they are actually much more sensitive to stimuli. This decreases their ability to cope with stressors and affects their reaction to rewards. These factors develop into a heightened awareness of their own and other people's reactions, which leads to harm avoidant coping strategies such as those listed to the side. Those are just a few. So treatment will involve recognizing that their sensitivity is both a blessing and a burden and learning effective tools for coping. Okay, now I'm pressing the arrow key and it's not moving.
Click on the slide again.
Right click on the slider. Well, that caused it to move. All right, so factors that impact eating disorder development, just like with other types of mental and behavioral problems, there's a combination of biological factors, psychological factors, and social factors. I'm not going to go through all these. You can read them, but I would like to make the point that genetics plays a really large role, and we're finding out more and more that it does, and that the genetics actually impacts the psychological expression of the genetics, such as cognition and affect regulation. And then the social factors sort of are also another characteristic that impacts the other two. So it's like almost like a downward spiral. The social factors just being in our culture and history of trauma, family culture. So I wanted to talk about some of the genetic components, and the first one I'm going to talk about is the serotonin connection. The serotonin, one of the genetic variants is called the low expressing short gene, and there's numbers there if you want to Google and research. And what it does is it affects the amount of serotonin in the brain by lowering the amount that the person has available both in their brain and gut. And when you have this variant, you tend to have an increased propensity for depression, which is why SSRIs help, elevated amygdala reactivity to threatening stimuli, increased depression and suicidality after stressful life events or childhood maltreatment. The symptoms include increased conditioned fear responses, increased auditory startle response, and greater nervous sympathetic reactivity when observing somebody else in distress. And as I mentioned, it's both in the brain and the gut. So we know this is true for people with depression, OCD, and also they found these abnormalities in eating disorders. A few of the studies, just very briefly, they have found that this increases sensitivity to the negative impact of childhood stressors. So one child is more reactive to the same thing happening to another child. So for instance, I always like to talk about my two cats. One, if I knock over a glass and it makes a loud sound, she will hit the ceiling and run from the room and hide for 2 hours. My other cat, if the same thing occurs, he will look at me, wag his tail, and tell me I better clean that glass up quickly before he steps in it. And these two cats had the very same thing happen, but they're wired differently. Just like people, I assume my first cat has less serotonin than my second cat. So they live in the same world, but one cat perceives the world as more dangerous. And this is what we know about people who develop eating disorders, is that they are sensitive to what happens around them, making the world feel more dangerous, and of course leading to harm avoidance. It's also related to anxiety, behavioral inhibition, and body image distortion. It interacts with traumatic life events similarly as I discussed with my cats, and it does predict increased likelihood of an eating disorder or bulimic symptoms. Secondly is the dopamine connection, another neurotransmitter that if you have increased dopamine binding, meaning less available, you tend to have more cognitive response to feedback. So you worry more. So it's related to anxious anticipation of consequences. However, there's a lot of controversy in the field about, not controversy, mixed findings about the role that dopamine plays, because in some studies, more dopamine seems to cause more problems for anorexics, and in other studies it seems like they have less dopamine. And I've tried to make sense of that, so I have just a very preliminary guess at what might be going on. I'll talk about it in a minute. When they blocked reuptake in dopamine so that there was more dopamine available in the system, people with anorexia were able to increase their weight gain faster. And they find that people with anorexia have altered serotonin and dopamine functioning. That means those are genetic abnormalities that affect weight. Okay, so these are more studies, and I don't think I'm going to take the time to go through them. What I'm going to do is go on to my summary. So preliminary conclusions are that there are genetic variants which cause lower levels in serotonin. These are found in anorexia, bulimia, and binge eating disorder, and it causes these individuals to be more prone to anxiety. There are also premorbid differences in dopamine functioning, meaning before they develop the eating disorder, so it appears to be separate from weight changes that are due to genetic variants. And they're different depending on whether you restrict or are impulsive with food. So some studies suggest that if you have too little dopamine available, then you're not as rewarded by food. Whereas if you have more, you have a different genetic variant, which causes you to have extra dopamine and be more responsive to rewards, which might lead more to binge eating behaviors. Furthermore, as the eating disorder behaviors are engaged in, it is like a downward spiral, because then that further disrupts the functioning in both the serotonin and the dopamine centers. And then stress also will interact with these genetic factors. So it's kind of a perfect storm for these people. So let's talk a little bit about screening and diagnosis. I'm not going to go over all the criteria for each of the diagnoses, because I know that you can read that in the DSM-5, but what I would like to do is point out some trends that are coming about that were apparent in the DSM-5, the new version, and what I think they mean. So there's been a real lag in interest and research, and even sort of charitable organizations rallying behind the needs of people with eating disorders, even though they, as we talked about, are one of the deadliest disorders that a person can develop. But there's also good news. So when the DSM-5 came out, in their criteria with anorexia, they took away a couple of key requirements. So if you look at the bottom, and I see that I misspelled a word, it no longer requires a weight criteria. When I first started in this field, you had to be 25% below the expected height for your weight based on BMI, to get a diagnosis. So to give you an idea, that means if you were 5 feet tall, you had to weigh 75 pounds to get a diagnosis. If you're 75 pounds at 5 feet tall, you need to be in the hospital. And so people would have to get that sick before they could get insurance support. Later in the 90s, I think it went to 15%, which made a lot more sense. But the great news is that they now have taken out the specific weight criteria, because we found that people can be extremely compromised medically, even if they are significantly larger than a BMI, a normal BMI. So what we're learning is that weight is very dependent on genetics and is very wide-ranging in what's right for any person's body. They also took out the criteria for menses, which the men appreciated. However, it's also helpful for many women who couldn't meet that criteria. They would continue to menstruate even though they were very low weight and losing heart and brain tissue. And that's just because some of us are very robust in certain physical ways. We might have a heart problem, but not a liver problem. And some people are robust for menstruating and could not get the diagnosis of anorexia for that reason. Now I'm going to talk about bulimia, and the difference between bulimia and anorexia is that there doesn't have to be the weight loss. There does have to be the binge eating, and then some type of compensatory behavior. You can read about that here. The change in the DSM-5 was that it went from having to occur twice a week to once a week, which was very helpful. Some people would not binge 3 times a week, but then they would binge and purge 10 times a day, or they might only regularly kind of have a ritualistic binge and purge on a Saturday night. And that is very disordered and eventually leads to usually more serious disorders. So that was a very good sign. Binge eating disorder, the greatest change there is that it actually became a diagnosis in the DSM-5. We had to use the not otherwise specified category before, and only certain insurance companies would honor that, but now it does have its own diagnosis and code. And again, the binge eating only needs to occur once a week. I'm going to also talk about other specified. That used to be the not otherwise specified category. They changed it to other specified feeding and eating disorder, called OSFAD, and it's basically for any person that is clinically diagnosed with an eating disorder but doesn't fit perfectly within any box, which it makes sense because a lot of these diagnoses, people go from one to the other in point of time, and it makes it a lot easier to go ahead and diagnose and get insurance support. And the interesting thing is that they added ARFID, avoidant restrictive food intake disorder, to the eating disorders. It had been a diagnostic criteria, but it had been a part of the anxiety disorder category. At first I was a little taken aback. I didn't quite understand, but as we've started working with people with ARFID, I think it's really good for people who work with eating disorders to be very familiar with ARFID and maybe develop skills, because ARFID, I believe, is a risk factor for developing an eating disorder. ARFID is generally when somebody loses weight not because of their body image. It is because they have sensory problems or possibly had a choking experience and now are afraid to eat. But in our society, if somebody starts losing weight and people start commenting on it, then that is a risk factor for go ahead and becoming focused on body image and developing a full-blown eating disorder. And treatment is similar, so it makes sense to me now that it is in the eating disorder category. And I want to talk a little bit about orthorexia as well. Orthorexia is the thing that a lot of therapists who do not specialize in eating disorders might come across. This is a term first coined by Stephen Bratman in 1996, and it is an intense focus on eating pure or healthy foods. So I'm sure you've heard the terms clean eating, pure eating, and then all the diets that kind of plug into that preference. And this is when one of those diets has sort of taken a life of its own, which is very easy to have happen with people who already sort of have a profile toward anxiety or perfectionism. So it's usually driven by food quality, by the quality of the foods versus the quantity, which is more a factor in anorexia. However, they may choose to go without food rather than eat something unhealthy, and it may begin to become an obsession and interfere with normal life functioning. Often co-occurs with obsessive compulsive disorder. And what I have on this slide is proposed diagnosis proposed criterion for a diagnosis, which was brought to the developers of the DSM-5, and they didn't feel like there was enough research yet, but it can serve help for us clinicians. And I'm not going to read it all again, but criterion A is obsessional preoccupation, to the point that the diet, does become unbalanced. And on this screen, you can see where it overlaps with anorexia and OCD, and there's a lot of overlap. And some people, I think, are vulnerable to all three and can sort of go either way or even develop characteristics of all three. Interestingly as well, all of these disorders have been linked to the variants in genes that we talked about with serotonin. So if I could see a show of hands, I would ask how many of you work with people with eating disorders, but of course I can't see that. And it's a trick question, because if you've worked with 15 or 20 people, you have worked with somebody with an eating disorder, whether they told you or not. And I have worked with a lot of people over the years who told me they went to a therapist for several years who they really liked and felt like were helped by, but they never told them that they were purging. They were too ashamed to say that. So what I would like to suggest is that if you don't already, that you have a very brief, non-intrusive way of bringing this up and having a conversation with every person that you meet with. These questions right here actually came from a research study in 2017. You can email me if you'd like the source. I thought it was on the slide, but they are 4 questions. And if you get the 4 questions checked in the positive direction, meaning that the person does these things or has these problems, then you this is statistically significant. You do have an eating disorder if you get 4. If you get 3, you probably have an eating disorder. If you get 2, you still need to have a conversation. And if you get 1, depending on which one, it's probably your neighbor, because most people in our society do have some issues with body image and food. So I just encourage you to integrate that in whatever way works with your however you start working with someone and developing a treatment plan. All right, I'm going to talk a little bit about medical and physiological considerations for eating disorders. First of all, I always like to talk to people about what happens when you get hungry, because regardless of what form of eating disorder a person engages in, they usually try to be hungry some of the time. Hunger is a part of it. Even for the people that I work with who are binge eaters, oftentimes the next day they try to make up for the binge by skipping breakfast or lunch. And so they often are affected by hunger and the consequences of hunger. So I'm going to go through that. I like to use a deer metaphor. I think that it helps a person who is dealing with an eating disorder and maybe a little bit defensive about it, especially about speaking around issues related to eating more. It helps them take a step back. And so I say, if there is a deer in the woods and there's a snowstorm, let's talk about what happens to the deer if, and I say she most of the time, if she has trouble finding food. So first of all, she searches for food. She begins looking around. She can't find food. If several hours pass, of course, she feels hungry in her stomach, which increases her drive to find food. And eventually, a couple more hours pass. If it gets to be about 3 or 4 hours, she will have an increased production of adrenaline. This adrenaline is produced to help give her a false energy to motivate her to continue looking for food, and even though she is beginning to be fatigued. So the adrenaline, if you're out in the woods looking for food, actually feels helpful. But let's say you skipped breakfast and you're sitting in a classroom taking an exam, and you have this extra production of adrenaline on top of whatever anxiety you might have, then it's not going to feel good at all. In fact, it's going to raise your anxiety and make it difficult to think about anything except food, because that's its point, is that if you're this hungry, you shouldn't be thinking of anything but food. It also is the thing that sometimes if we go too long without eating, we have hunger, the shakes, your hands will tremble a bit, and that's just adrenaline not being used for the purpose that it's designed for. So let's say she goes on through the forest and she doesn't find food, and it gets dark, and she's very fatigued. She may try to sleep, but she's going to have a very light sleep because there's still adrenaline being periodically pumped into her system, and she's going to wake up frequently. So sleep problems is one thing that we oftentimes come across people with eating problems, and sometimes they're on several medications to help them sleep. And I've been known to say very often the best medication for you if you're hungry when you go to bed is 2 tablespoons of peanut butter. And I get mixed reviews on that. Another thing that happens to the deer before it finds food is, as I mentioned before, there's a real cognitive narrowing in what she can pay attention to easily. So selective attention. The deer really does not care about anything but finding food, and everything will remind the deer of food. So this is where you have people get obsessed with food channel recipes, cooking for other people. Really, it becomes so attention grabbing for them, which is physiology. But a lot of times I'll say, I don't even eat it. What's wrong with me? Why am I so obsessed with food? To the next point, obsessing about food, and that is just physiology. It's just your brain trying to motivate you to find food. And with that selective attention comes a decrease in social interest. If this deer is walking in the woods and it looks over and it sees a buck, and I don't care how good looking this buck is or how many points he might have, this deer is not going to be interested. In fact, if anything, he's just competition for what she really wants, which is food. So there, you'll find with people with eating disorders a real decrease in social interactions. And on the surface, it seems, and it is in part related to just fear of eating situations, but it's also just a narrowing of interest. And finally, let's say the snow thaws and the deer does stumble across a bush that has thawed out and is full of berries. Do you think that the deer is going to eat one serving? And of course, the answer is no, the deer is going to binge eat. So I try to help people I work with who, if they don't binge eat, they know the urge, they feel the urge because it's a physiological, biological mechanism. Binge eating is normal in that condition. So a lot of people come in and that's the thing they feel the most shame about, and yet it's a normal physiological response. So that's the complications of hunger, but as you can see in this slide, that there are complications of just about every system, of course, because nutrition is going to affect every system in the body. I'm not going to read over all of this. It's here for you to look at. It's interesting how many people I've known who've had gallbladder stones or had to have their entire gallbladder taken out. Colon, sections of colon, tears in the esophagus. An interesting thing about bone loss, we used to think that the bone loss was reversible, that these girls who were putting themselves in premature menopausal states and losing bone because of it were, once they started eating again, would be able to grow bone. And it turns out that that is not really the case. And most of the people, well, I don't know exactly at what point, but that it is less reversible than we first thought. Okay. I'd also like to talk a minute about refeeding syndrome, which is it's not a consequence of undereating or overeating, but it's a consequence of therapy. It can be. So it's a potentially fatal condition caused by the initiation of refeeding after a period of undernutrition. I want to say that the person does not have to be underweight, but if they have lost quite a bit of weight, and then they start refeeding, they are in danger of refeeding syndrome, and it can be fatal. Potentially fatal shifts in electrolytes can cause a heart attack. It usually will occur within 4 days of starting to refeed. So if you meet somebody and they told you they lost 50 pounds, but they've gained back 10, they're not in danger of this. It's at the very beginning of the process. And this is criteria from the National Institute for Clinical Excellence. If you do meet someone, whether or not they say they have an eating disorder, and they meet one or more of the following on the left, then you should have them referred for medical testing, and also make sure the doctor knows why, because there are a lot of doctors who are unfamiliar with refeeding syndrome. So a BMI of less than 16, and yes, that's on the old criteria, which is still used in medicine and in insurance companies and in Walden, because we have to get insurance coverage. But but on the second category, you can see it doesn't have to be a BMI of 16. It can be weight loss 15% or more over the last 3 to 6 months. So 15% for someone who is 5 foot would be 15 pounds. So you'll oftentimes have people coming in telling you they've lost 30, 50 pounds on this whatever diet, and then you want to ask if they're still losing, they need to be seen by a doctor if it meets that criteria, or if, regardless of weight, if they've had no nutritional intake for 10 days, or if they have lab work done and they have low levels of potassium, magnesium. And one thing that you can't rely on, but I will say, if you see swelling in the ankles in someone who's lost weight, this is one of the signs we always look for, and immediately send the person to the ER. That means the fluids have shifted and they could be in danger of a heart attack. All right, let's see how we're doing on time. Okay, now we're going to talk about treatment. So one thing that is exciting about the work we do at Walden and in other places is family-based treatment. Walden actually does a family-based IOP, so they bring the families in for group therapy 3 days a week. So the parents have to make a commitment to come, at least one of them, for 3 days. I am so excited about this program because we used to have people who would be frustrated, that they would learn things like DBT and CBT and labeling emotions, and they'd go home and nobody else, friends or family, even taught the language, understood what they were saying. So in this program, we actually help them develop a language together as a family. We consider it an alternative to inpatient if the person isn't medically compromised. Evidence-based, there's a lot of evidence, I do have some sources that you can look at. It's based heavily on a structural family therapy for you family therapists out there, in that the parents are put in charge. Now, a lot of people feel like this is a little bit harsh, but if you take a child and put them in the hospital, they are then, the hospital is in charge. So I would prefer to see the parents be the ones in charge, and the parents learn what they need to learn, then go to the hospital and come back to parents who are still in need of the learning. So the parents are empowered to be the primary vehicle to refeed the child, and then the therapist is more of a coach. There's 3 phases. So phase 1 is refeeding, where the parents are completely in charge. The child, and when I say child, we do 11 through college, although college is rare. That's developmentally inappropriate in most cases. The parents are put in control, and the child really has no control, just as if they were in a hospital, because if they're not able to take care of themselves, we believe that they need someone to take care of them. Phase 2, though, is sharing control, and then phase 3 is returning to the adolescent whatever is developmentally appropriate at that time. Hopefully, they then can be making all the decisions about food choices and where they want to eat and who they want to eat with. Another core approach for working with eating disorders is DBT, and There's 4 modules, and these modules have been very helpful in group treatment for people with eating disorders. We're not going to be really going into that in any detail right now, but just letting you know. What I am going to talk a little more about is body image, because again, body image is probably the thing that no matter what type of eating disorder people have in common, and your clients who aren't eating disordered or maybe subclinical eating disordered may also be struggling with body image. And so I think there's some strategies here that can be really helpful. So the Health at Every Size is an approach to body image that adheres to the idea that it is possible at any size, even very large sizes, for the person to be at health because it's genetically driven. And that doesn't mean that every person is healthy at every size, but that you can't look at somebody's size and know that they're not healthy, because it's possible they could be. So it's biology rather than lifestyle that usually naturally directs the body's weight, shape, and size. And health is a result of healthy behaviors as opposed to weight or shape. Weight is a poor indicator of overall health, and that has been substantiated in lots of studies. Research has shown that diets don't work. It's a fabulous marketing approach, but they don't work. So there's a couple of references there that you can look at if you want to read more about that. I'm going to talk about a program that Alsana does, developed by Amber Paris and Mary Elizabeth, which I've incorporated parts of into our program, and I'm not going to go over all of it, but I'm going to just introduce it to you. It's called Body Embrace, and we have known for decades that body dissatisfaction is usually the first and often the strongest activator of the eating disorder behavior. And the interesting thing is it's the hardest thing to have go away. My experience is that people's body distortion does not go away for over a year after they're have normalized their relationship with food, which makes it very difficult for them. They have to kind of keep eating the way that they're recovery eating based on faith. The phases are assessment, tolerance, acceptance, and compassion. I'm going to jump to tolerance. So learning to endure the body dissatisfaction without utilizing eating disorder behaviors. So distraction, mindfulness, anything where you're kind of using your body to move can be helpful in that phase. Body acceptance is a step beyond tolerance, and it's not self-love. As you might see, self-love, body love was not, love your body is a phrase that we use a lot, but it's not one of these phases, because for some people even who are recovered, that never becomes something they can achieve. So body acceptance, some of the strategies here are using a body image timeline, having the person just go through their lives and consider the different things that have impacted their body image, just to increase awareness and maybe some acceptance. There is a gratitude body scan, which can be done either with a mirror or through imagery if the person doesn't want to look directly in the mirror. And this is an activity where you ask the person to look in the mirror or imagine that they are at their face, and then just to identify the things on their face that allow them to do something, and if possible to thank it. So thank my eyes. I thank my eyes that I can see, etc. Then you might move to arms or hands. I thank my hands that they allow me to hold hands with someone. And then it continues that way. And then moving on to the body compassion phase. So after you've practiced body gratitude, and I ask people to actually try to develop a discipline of waking up in the morning, speaking to their body as they would an old friend. You're not expecting your friend to look perfect or have the perfect body, but you appreciate that they are connected with you and what you've been through, and that they're there for you. Same with your body. To try to wake up in the morning, say, hi, glad you're here. I appreciate you. If you practice that for a while, it is possible to move into the body compassion phase. Still might not be what somebody would tolerate calling body love, but they can feel compassion. And at this point, you might do another mirror scan or an imagery where you look at the body parts and you actually try to express compassion for each part. All right, now we're going to move to the other thing that is very common when working with people with eating disorders, also substance abuse, and really just about any time you're asking somebody to change something is some resistance to the change. So when people pay hard-earned money, give up their valuable time to meet with you weekly and avoid what you're doing, what you say, that's probably some resistance. I like this quote at the bottom: psychotherapy is no profession for someone who likes certainty, predictability, or a fairly constant sense that one knows what one is doing. Paul Wachtel. I kind of like all those things, so I had to find a way to deal with resistance. And I'm going to have to go through these slides very quickly because I'm aware I just have a few minutes left. In fact, I'm going to skip this one. But what I'd like to do is go ahead and tell you that at the end of the slide is a reference to my book, and you can read all about dealing with resistance, in which actually I have reconceptualized as ambivalence. So when people are torn, I think it comes about when there's a sensitive person, think serotonin, who's raised in an insufficiently validating environment for this child. So it doesn't have to be bad parents or trauma. It could have been, it could be experienced as trauma. Let me take that back. It doesn't have to appear to be trauma. Then certain needs will go unmet. And when there is a conflict in needs, such as wishing I could have it but knowing I can't, feeling that need to be safe by not connecting but wanting to connect, then you're going to have pathological ambivalence. Pathological meanings it interferes with your ability to live a life worth living. You might hear influences of Linehan and DBT there. So when somebody is ambivalent, the most natural thing for therapists to want to do is to encourage them toward health. But what often happens when we encourage somebody to help is that they just jump over to the other side of their ambivalence and hold it even more tightly. Because we're holding the voice of help, then they go over to the reasons why they're afraid of making the changes. We say, you can change. They say, I don't think I can. We say, have hope. They say, I don't have any hope. I'm afraid to hope. So instead of doing that, with people with pathological ambivalence, it is best to stay out of the split. So ways to stay out of the split are to assess their beliefs, the beliefs they have about themselves, others in the world. You can use some standard approaches to beliefs from cognitive therapy. I have a list of a checklist you can use in my book. Consider the client's interpersonal system. Don't believe everything you hear. So I'm going to tell you a story about a client, and I'm going to give you the real abbreviated version here. But she came into our program and said that she was a binge eater. She was on disability. She had quit 2 or 3 jobs. She said at her last job, her employer had trapped her in a room and wouldn't let her out. We were all horrified. She came into the program and she was very inconsistent. Sometimes she would be a really great group member and had a great insight, and other times she would seem very childlike, defensive, and angry. And then one day she came to her therapist and said that one of the male therapists in the program, male patients in the program, had trapped her in a room and wouldn't let her out. And we were all horrified. So I decided to have a meeting with her to hear more about it. And we were actually considering, do we need to ask this young man to leave? This young man had anorexia and he was 19. And as I talked to this woman, it occurred to me I had heard those exact words before. And so I said to her, so tell me more about how you were trapped. And I'm not going to go word for word, but she had interpreted herself being trapped because he was so eagerly wanting her to understand what he had said, because he was afraid he had been misunderstood, that he was being energetic. Apparently, she could have walked around him, but I think she was in a young ego state, and she didn't know she could, maybe without being hurt. And so I asked her, what do you need in a moment like that? And she said, what I need is to be able to see that that was just a 19-year-old kid, and I could have walked away. And I said, yes. And so There's a whole lot more to this story, but what turned out is we talked about what can we do so that you never have this feeling again. So we never had to talk about the reality of the situation. Sometimes people come to us with stories, and we can't know the reality of the situation, but we can talk about, well, what do you need when this happens? Keep the eyes on you. Don't necessarily believe the story. As they tell it, it's probably oftentimes a distortion. All right, another strategy is to answer questions. Before answering a question, get the client to identify what she needs. So I had a client who said, "Are you mad at me?" And I said, "Well, before I answer that, if I were mad at you, what would you need? How would you feel about that? If I weren't mad at you, how would you feel about that? If I were mad at you, what would you need from me? What would you need from you?" By the time we finished that, I never had to answer the question. I don't have time to go over all these. I'm going to be cautious of over-interpretation or over-validating. We validate because we were trained to, and we're good people, and we want to believe what we hear, but oftentimes when we're validating a distorted perception, it's not helpful. So notice here the definition of validate is check or prove the validity, to be able to demonstrate or support the truth, and make or declare legally valid. So as you look at this cartoon, you might see my point. So I can't hear you laugh, but I'm going to assume you did. That's not what he wanted. So when we validate, oftentimes it's not really what the person needs. What they need is eyes on them. And we can't validate what we don't see anyway. I will make the point that I do validate anything I do see as best I can. So if someone's mad at me, I can very much validate that. But if it's about someone not in the room, then I can't. Okay, I'm just going to fly through here because we're out of time. I have a group of strategies for how to help people understand parts, and that parts are the reason why they are ambivalent. I have another group of strategies for helping people integrate parts in a healthier way. Some of these you know, probably most of these you know. They are just organized so that kind of along a roadmap. And then again, strategies for integrating parts, such as letter to self, maybe from a child part to an adult part. And then I'm going to end by saying when people have when they have ambivalence, pathological ambivalence, then they have developed a narrative which may need to be reviewed and rewritten. And there I am. There's my book. Those are my blogs and my website. You can email me through my website, and I am now open for questions.
Wow, thank you so much, Dr. Buchanan. I do have one quick question that kind of throws back to the beginning, but while we're answering that, if anybody else has any other questions, it gives you a little bit of time to type it into the chat box, and we'll be sure to address it. So that being said, somebody asked towards the beginning of the presentation is if you can test for serotonin levels.
Yes, but most practitioners are not doing that because it's just too expensive. We get these studies from universities where they're given grants to test for things like that, and it is possible.
Right on. Anybody else? If you are typing right now, we'll give you a minute. I'll go over a few things real quick. As I mentioned before, we do record all of our webinars and would be happy to provide an audio recording. If you're interested in the slide deck, as Dr. Buchanan already said, please reach out to her through her website and email her through there. And as for the audio, if you would like it, please email me, cweeks@harmonyfoundationinc.com, and I will be happy to share the audio with you. For those of you who are interested in our next webinar, which is on June 22nd, we do have Melissa Barbash talking about helping women in partnerships affected by addiction. So please look out for that registration email, as it will be going out in the next week or two. Just a reminder, when you do receive the survey today, please be sure to include your suggestions or topic ideas. We're always interested in hearing from you, so those become quite useful. And I'm checking for more questions as far as the PowerPoint slides being emailed. As I said, you need to request those through Dr. Buchanan. Thank you so much for this great webinar. We are so glad you were able to jump in and present to us on this webinar. We appreciate you sharing all your information.
And notice that I put in the chat box a 20% off code if people want to use that when they order a book.
Oh, wow, that is fabulous. Thank you so much.
Can you see that? Did I put it in the right place?
I can see it. We'll give everybody a couple minutes to look at that. So I do have another question here. Says how let's see, how this is going to be a big word for me. Predictive is eating in secret developing a disorder. Also, we need to, I'm sorry, go ahead.
That's definitely a warning sign.
Okay, so the rest of the question says, also, we really need to get more discussions going about all of this. So what other ways can we encourage dialogue with people's unhealthy eating habits?
Well, that is such a great question because I am an advocate and I'm always looking for opportunities like this to get the conversations. I go to schools, blogging, you know, it's hard. There's not nearly as much interest, as I said before, in this area as others, although we all struggle with it every day in our lives and with our friends on some level. So, you know, email me, let's brainstorm together.
Oh, awesome. That is something that even as having a daughter, I worry about paying attention and how to talk about it and how to encourage the ability to do that. So it looks like we are not able to see your code.
Well, let me say it.
Okay.
It's
Is everybody
20%
ready?
off.
She's gonna say it.
It's 20% off, and it's Path Ambiv, PATHAMBIV. So if you go to the website under the title of the book, it will give you a chance to put a code in, and then that's it, PATHAMBIV.
All right. And I'm sure if anybody emails you for that same code when they're requesting, we might be able to acquire it that way as well.
Sure.
Awesome. Thank you so much, Dr. Buchanan. We really appreciate you joining us today. To everyone else, on behalf of Harmony Foundation, thank you so much for participating in our webinar series. We hope that we will see you again next month. Have a great day.
Thank you.
Thank you.
Done.